Hello, I'm Dr. Sagar Lonial from the Winship Cancer Institute of Emory University in Atlanta, Georgia, and our topic today is going to be talking about BCMA CD3 bispecific antibodies in myeloma, current and evolving roles. And there really are a few topics that I want to touch base on a little bit. The first is the evolving use of BCMA-directed bispecifics in the context of high-risk smoldering myeloma. And there certainly are very encouraging trials that have been performed with BCMA-directed bispecific antibodies. But I think what we're really excited about are trials potentially looking at elranatamab in this space as well. And what this really offers us is the ability to achieve deep and potentially durable responses in a high-risk smoldering patient population. Now, we recognize that high-risk smoldering certainly is an area where there's a lot of work being done, and a lot of that work has been focused on using anti-CD38 antibodies or using lenalidomide or combinations of the two. And recently, with what we hope will be the first full approval of a treatment in high-risk smoldering myeloma based on the Aquila trial, this idea of evolving with immunotherapy-based approaches, particularly looking at elranatamab in this treatment space, is really very, very exciting because we know that these treatment approaches can be very quick. They are associated with potentially short-term increase in potential side effects or toxicities, but in general are tolerated very well. Now, another area that there's an evolving treatment paradigm is the area of AL amyloidosis. And we know that VCD plus daratumumab has been a standard in this treatment approach for a period of time. But again, looking at BCMA-directed therapies are another area where you get very effective, highly active treatments achieving potentially MRD negativity in a very short period of time. And this can be achieved, again, looking at agents such as BCMA-directed bispecifics, and is specifically being tested with elranatamab in this as well. I think what we're really excited about is the idea that diseases like AL amyloidosis or even smoldering, as we discussed before, are often disease states where the true tumor burden is lower, allowing for potentially shorter duration of therapy and potentially limiting the frequency of administration, which may ultimately improve tolerability and outcomes for a number of these patients. And as we think about challenges and specifically resistance mechanisms in the context of bispecific antibodies, to me, one of the biggest questions is how often do the patients need to be dosed, and is there a point at which one can discontinue therapy? And this likely will come up even more when you're dealing with low tumor burden situations such as AL amyloidosis or high-risk smoldering, where perhaps patients who achieve early MRD negativity that is sustained for a fixed period of time can go to less frequent or even discontinuation of dosing and understand exactly how long that remission can last. So these ideas of preventing mutations in the BCMA receptor by reducing the frequency or even discontinuation of therapy, I think really are very, very exciting, and I think give us the opportunity to achieve new and deeper responses in many of these disease states than we've previously been able to do in the past. Now, as we're talking about using things like BCMA bispecifics in the context of amyloidosis, as well as high-risk smoldering myeloma, there certainly are trials that are beginning to evaluate combinations of BCMA bispecifics in the context of newly diagnosed myeloma or in early relapse. And these phase 2 and phase 3 trials are certainly very encouraging. The other area where I have significant interest is perhaps among patients who are persistently MRD positive. Is there a way to give short duration BCMA bispecifics to achieve MRD negativity, similarly to what is done in ALL, where patients who are MRD positive are given short duration bispecific therapy and then achieve MRD negativity that can, in many settings with ALL, ultimately be curative of the disease overall. So these kinds of concepts about not treating until progression, not keeping the same weekly or every other week dosing schema, but going to much less frequent dosing, whether it's monthly, every other month, or every third month, that allow for normal immune recovery and potentially reduce the risk of infectious complications are areas where I think we're going to make significant strides and ultimately improve outcomes for patients. Now, the area that I think is most exciting is about the ability to really limit the impact of even coming to the infusion center for many of our patients. And this is being championed in Europe, where the idea of home or community administration of BCMA bispecifics is beginning to take hold. And it's being studied in a number of different areas. At our center, we actually give preemptive tocilizumab to maintain outpatient administration of BCMA bispecifics, and that reduces the CRS rate from 60 to 70% down to almost 20%. But if you're beginning to talk about beyond the step-up dosing situation, it is possible that even with every other week or once a month dosing of a bispecific, that patients could potentially receive subcutaneous formulations at home. And this is being tested in the context of clinical trials to truly understand safety, which obviously is a paramount concern when it comes to delivering bispecific antibodies outside of the clinical office space or the infusion center. And these, again, are being tested and evaluated in real time in clinical trials currently. So I think you see there's a wide range of clinical trial opportunities for us looking at BCMA bispecifics, not only in the context of high-risk smoldering myeloma, but also in the context of AL amyloidosis, in newly diagnosed or first relapsed myeloma, and ultimately more patient-friendly delivery mechanisms such as home delivery once you get past the step-up dosing and the incidence of infusion reactions really drop. This allows us ultimately to give patients more control over treatment and management of their disease, and we hope allows us to create treatment-free intervals where patients can have improved quality of life, can have some level of immune recovery, and we hope even ultimately be cured of their disease overall. Thank you for your attention.